Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. Today's podcast is brought to you by the Residents and Fellows Committee. For more episodes of this podcast, visit www.auanet.org/podcast.
Hello, everyone. My name is Sam Ivan. I'm a reconstructive urology fellow at Fox Chase Cancer Center and Temple Health in Philadelphia, Pennsylvania. I also have the opportunity to serve with the Residents and Fellows Committee of the AUA. And tonight, I'm joined by two very close friends and colleagues, Dr. Alison Keenan and Dr. Kayla Graham from Carolinas Medical Center in Charlotte, North Carolina. We're going to be talking about a new and unique method of outpatient urology education that they've been using at Carolinas Medical Center for the last couple of years. And I'm really looking forward to talking with them more about it. I'll just briefly have both of them introduce themselves for us. Allie, why don't we start with you?
Thanks, Sam. My name is Allie Keenan. I'm a pediatric urologist. I have been the associate program director for the last couple of years here at CMC, and I'm taking over now as program director. And have always had a long-standing interest in resident education and been involved in residency programs since I graduated fellowship. So happy to be here. Thank you for having me.
And I am Kayla Graham. I am a rising PGY4 at Atrium Health Carolinas Medical Center Urology Residency in Charlotte, North Carolina. Also a new member of the Residents and Fellows Committee representing the Southeastern section. So excited to be taking on this endeavor with Sam, and excited to be here to chat with you guys tonight.
Great. Thank you, guys. Allie, I want to start with you. I know you've spoken about this topic before. You did actually a great Backtable Urology podcast several months ago. And in that, you guys really laid the foundation for why outpatient or ambulatory urology education is crucial for urology residents. Today, I want to talk a little bit more about what the longitudinal resident clinic that you guys have put together is, how it works, with the idea that maybe listeners from other programs or medical students looking at programs might hear this, and it might spark some ideas for them of how to improve education at their own institution. But just before we get into that, can you give me a quick summary from your point of view as a practicing clinician? Why is ambulatory education so important for urology residents?
I think that is probably the most important point, and something that I definitely did not appreciate when I was a resident, because clinic felt a bit like a burden. But then as soon as I got out into practice, which for me was pediatric urology, but I think the same applies for almost everybody, I just felt completely helpless and out of my depth, and realized that I felt very comfortable in the operating room. I felt very comfortable managing, consults on the floor and on the fly clinical questions, but I really did not feel comfortable managing patients in clinic. When do they come back and see me again? What is normal follow-up? And a lot of those questions were things that I realized I had not properly taken the time to learn or been taught, for that matter. And then what struck me over the years is that I think so many people share that experience coming out of residency, and far and away the most frequent calls that I think our faculty get in the first couple of years from new graduates are about clinic questions. And that really, I think, drove home the point for me, as somebody interested in resident education, that teaching ambulatory or outpatient portions of urology are critical to, kind of developing a well-rounded resident. And we tend to focus on the surgery part, I think, naturally, because for one, it's what we all enjoy. And two, it feels like the most dangerous part of our job. And so that must be the part that we should spend the time teaching. But in reality, a lot of those decisions that lead to the OR can be just as dangerous. And I think that those are the things that we need to focus on teaching, but forget. And so I think that's why it's so important.
That's such a good point. That perception that we have of the dangerous part of our job. I've never thought of it like that before, but that's such an interesting point. We think, the most dangerous thing we can do is operate on somebody, but you're right. That always starts with the decision to take them to the OR. That's such an interesting thought. Okay, Kayla, give me the other side of that coin. Why is ambulatory education generally so undesirable to residents?
Mhm. I think Dr. Keenan sort of touched on it already, but I think we all go into surgery or a surgical subspecialty like urology because we want to operate and we want to fix the problems. And so we want to get our hands in the operating room. And clinic is, whether it's said as a joke or not, a lot of times people say clinic is just a, a place to book cases and get people to the operating room. And so I think when you're primarily focusing, like Dr. Keenan said, on taking care of patients in the operating room, performing the surgeries, knowing how to handle complications and manage immediate peri-op care, you don't prioritize the things like how to decide when to get patients there and what to do once you get them out.
And so, Kayla, what is this longitudinal resident clinic, and how do you feel like it's set up to maybe better prepare you for practice?
Yeah, so our resident clinic is set up for our PGY 2, 3, 4, and 5s to have our own patient population that we follow on a regular basis throughout those 4 years of our residency. Most other resident clinic models that I've seen are pretty up in the air. Everybody shows up. No one really knows what kind of patients are going to be there or what kind of pathology you're going to see. You've never met the patient before. You read their chart for 5 minutes before you walk in, and it doesn't help you to build relationships, really see any kind of progression of working up a problem. You don't necessarily see where those patients are coming from or where they're going in their care. You're kind of just checking a box and showing up in clinic. But our clinic is set up so that we are really able to use those 4 years to build long-term relationships with patients and see a progression of their care from showing up for their consult to booking them for the operating room, ordering all of their tests and having conversations with them when all of those result before getting to the operating room, seeing their immediate post-operative course, and then following them for the long term and learning every step of that way about how to manage those patients.
That's a really good overview. Summarize real quickly, what are some of those unique aspects that you think you're getting from this LRC model that you're not getting from other clinic experiences?
Yeah. For other attending clinics, especially, we show up and we probably have prepared some, know what the patient's coming in for, have looked at their imaging, but we kind of have a brief conversation with them about what brings them in, what their symptoms are like, and what their options may be, and then ultimately watch the attending kind of do all the heavy lifting in terms of coming up with the plan and having the difficult discussions sometimes with patients. Um, and then we help them write the note and we check out and we may never see that patient again. And so I think being able to follow those patients, like that you are their doctor, you are the one that is relaying all of their care to them, is having all of those difficult conversations. You really get to build a relationship with them over those years that you don't get to in anyone else's clinic. On the other side of it, other than just patient interaction, you have to run your clinic from a logistical standpoint. So if you want certain studies to be done, certain, like you want urodynamics or you want a uroflow or you want workup to be done before the patient gets there, you kind of have to look ahead and prepare your clinic, make sure that all those things are done. If you want someone to have a AUA symptom score when they show up, you have to make sure your nurses know that you want that and are preparing your patients in the way that you want them to be. It's up to you to figure out how in your day and in your schedule you're going to call your patients back when their elevated PSA comes back and have next steps conversations with them. You need to be the one to communicate with their infectious disease or cardiology physicians in order to help coordinate their care. So you really get a hands-on experience with managing all of the other parts that go into clinic that you don't usually see in your other attendings clinics.
Awesome. So I'm hearing maybe some of the patient relationships, some of the more logistical kind of coordination of care aspects, and then definitely the
Hmm.
continuity piece are some of the big
Yeah.
things. Is that right?
Yeah, definitely.
And Allie, I know you had a big part in starting this initiative. How was this purposely designed, and what were the things that you guys were thinking about as you were putting this together, trying to address some of those features or maybe address some deficits in sort of traditional ambulatory education?
First of all, you're kind, Sam, because I did not have anything to do with starting this. I totally rode the coattails of the whole thing. But I was there through, I think, the first couple years of iterations and learning and making it better. And that was really interesting. And I think what we learned was that to us, it seemed like continuity was the biggest and perhaps the hardest thing to focus on. And as you guys know, our residency program doesn't have a VA or anything similar, such that residents have kind of their own cohort of patients that they feel responsible for. We also, prior to the LRC being developed, had a community clinic that was mostly resident run that we knew was being shut down. And so our one sort of imperfect shot at resident longitudinal experience was closing, and we knew we had to recreate it in some fashion and that we should do it better when we made it. So things that we knew we wanted to build in was autonomy and a sense of ownership of the patients. And we felt that could really only be created if it was, Dr. Ivan's clinic or, Dr. Lou, one of our other residents' clinics. It had to be their personal clinic, not just something where they were kind of, a resident clinic that was a rotating door. So we started with that premise and I think learned from there.
Okay, that's a really important point, I think. So when patients are seen as part of the longitudinal resident clinic, they're showing up expecting to see that resident as their doctor. Is that right?
Correct. Yeah.
Gotcha.
That's really the fundamental piece, I think.
And, this, you mentioned a little bit that there was sort of a community clinic that was being sunset. And we haven't explicitly mentioned yet, though, that one of the pieces I know that you built in was that this resident clinic was going to be payer agnostic, that this was not going to be sort of for underprivileged or underrepresented patients, that this would be from the entire pool of patients referred to the urology practice. And so how has that played out from the standpoint of all different payer types, and then again from the standpoint of patients being scheduled to see a resident physician? How have patients responded to that? How has that played out?
Interestingly, the patients have responded really well. And as you know, Sam, because you published some of this work and presented it, but the payer mix has really been evenly distributed. And we worked hard at that. And when we looked at that data, we compared it to our general urology practice that runs out of the same building. And the resident LRC clinic payer mix was basically mirrored our general urology clinic. And what we have found is that the patients are completely willing and not prone to switching, because what we wondered was, would patients start out with a resident clinic because they're being distributed there sort of by random in some cases, but then would they want to switch out of the resident clinic? And that doesn't happen very much either. We really haven't had a substantial number of patients sort of want to opt out of seeing their resident physician, even knowing, that they're a trainee. So the payer mix has been well received. We do not treat it like a, kind of reduced payer mix clinic or charity clinic or anything like that. And the patients receive it well. They do not request to move out of their resident clinic.
That's, I think, really impressive and speaks to some of the opportunities of a model like this, I think. Kayla, on that same subject, can you tell me a little bit about your experience and comment on sort of relationships that you've had with clinic patients or how that maybe has impacted your view of clinical urology?
Yeah. Now that I'm nearing my fourth year, I've done almost 2 years of LRC. And initially, it starts out as a lot of consults and a lot of hospital follow-ups that you may or may not have been involved with. But then as you're booking more cases and seeing more patients in post-op and managing their surveillance and things like that, you truly get to build that relationship over time with your patients and get to know their family members and hear about their life outside of an acute inpatient hospital stay. That is not something you really get to experience as a resident with any other patient populations that you work with. So there's a lot of people that we will see as a consult resident for 6 months of our third year who will then follow up in our resident clinic. And so I've met a number of patients who are either uh, inpatient for acute renal colic or a septic stone or emphysematous pyelonephritis or some acute issue that we are the ones primarily helping to manage their acute inpatient stay, and then also see them on the other side of that and get to kind of experience who they are outside of one of their worst moments when they're in the emergency department and being admitted to the hospital because they're really sick. And that's a really cool relationship. And I think ultimately why a lot of people go into medicine is to be able to create those relationships with patients and have discussions with them about their long-term care and their goals and their family and those things that you don't really get to experience much throughout other experiences in residency.
Yeah, that's such a good point. And I'll editorialize here a little bit. Again, as you said, Allie, I did have some experience with this at the end of my residency. And I think for me, that was one of the most impactful things. When you're in clinic with your attendings, you can learn head knowledge, but you never really or very rarely experience some of those sort of heart moments with patients that sort of keep you coming back. And I think
Mm-hmm.
the opportunity to see people, like you said, Kayla, outside of their worst moments and get to know them a little bit long term, it creates some opportunities for those moments that I think bring a little bit of life back into medicine and back into urology. And I think that to me made that experience much more meaningful. So, Kayla,
Yeah.
tell me a little bit more specifically about how the LRC runs. How often are you in clinic? How many patients are you seeing? What kind of diagnoses and things are you seeing? Are you doing procedures? What's it look like?
Yeah. So it starts out somewhat small. When you are a PGY2 and a PGY3, you do a half day of clinic every other week. And you're paired with either a 2 or a 3, not your counterpart, but in the year above or below you. So that you kind of have somebody to bounce things off and have discussions with about your patient care. You typically will start by seeing about 5 or 6 patients per clinic, which is usually about 1 to 5, um, 1 p.m. to 5 p.m. And as you figure out how to have conversations with patients and go through these things quicker and go through staffing your patients with the attending who's overseeing clinic, and get more autonomy and responsibility in this clinic, you build up to now I'm usually seeing between 8 and 9 patients in an afternoon. There's a lot of consults, a lot of ED follow-ups, like we've talked about. And then as you start seeing more of these consults and doing more stone procedures, then you'll start seeing a lot of cystoscopies and stent removals. And then as you get into your fourth and fifth years, there are specific slots in your schedule that are reserved for procedures. So in the next couple of weeks, I have probably 6 or 7 vasectomies that are coming up. You do a lot of prostate biopsies. I think I have an excision of a penile lesion in someone in the clinic. So your schedule changes a little bit as you get more responsibility and experience with the clinic so that you start seeing more patients and do more procedures, and just get more autonomy as you get more experience.
Great. And how does this tie into the rest of your residency education, Kayla? Are you still doing clinic with your other attendings?
When we are 4 and a 5, our LRC actually changes to being a weekly experience rather than an every other week. So during those years, we do not have an overt responsibility to go to clinic with any other attendings. During our 2nd and 3rd year, when we are doing more of a mentorship-based model for our rotations, we do still spend at least 1, usually 2 days in clinic with the attending that we are paired with for that time period. Another really important part, I think, to the resident clinic and making it run is the buy-in that we have from all of the attendings in our program. Because when we book a case, we are expected to be in that case no matter what time of day it is, no matter which provider it's with, if we are on that rotation or not. And if for some reason we can't be there, the expectation is that we will have another resident prepared and aware and able to take over that case for us. Because again, those are our patients. So the expectation is that we are going to be present and be able to do their case. So in order to kind of be able to say, hey, I know I'm supposed to be in Stones with you all day, Dr. Patel, but I have an LRC robot case doing the ureteral reimplant with Dr. McKibben. Everyone has to be on the same page about that being the expectation and your priority. And so thankfully, all of our faculty are very supportive of that and knowing that that is our patient and that that's our primary responsibility.
Okay, that's a great point, and that's one of the tricky things about this, I think, is, this is a surgical clinic, and so you're booking surgeries. Allie, can you just comment from the administrative and the faculty side of that? How has that worked out? And what kind of faculty buy-in or resident flexibility has been needed to be able to get residents into these cases that they book?
Yeah, I think that has been a bit of a learning process, and I wouldn't say a slow start, but it did take some time for, I think, the faculty to truly appreciate what we were doing and to be respectful of it, which isn't to say that they didn't let it happen to begin with. I mean, I think, if somebody said, listen, I need to go and do this other case, people understood that, but also, I think from my perspective, part of being a program director is managing up a little bit, or at least managing out some of the other faculty, personalities and things like that. But that has really quieted down over time. And now I think that as a department, this is something that we consider, a bit of a pearl or a gem or something that we do differently and we're really proud of. And I think most of the faculty now are really supportive and proud of the fact that we run this clinic, that our residents get this experience, and that we as faculty support them, using these learning opportunities as they present themselves. And if that means leaving somebody's awesome once in a lifetime case to go cover their own LRC case, that's what we expect to happen.
Okay, one of the other things that you mentioned very briefly, Kayla, that I want to talk a little bit more about, and actually, Allie, I'm going to have you weigh in on this. You mentioned that you are staffing these patients with a supervising attending. Allie, talk to me about how that works for the LRC and how you see that happening long term, and maybe what pros and cons of different ways maybe to staff that clinic are.
Yeah, we are extremely fortunate, I think, here in Charlotte to have, I think, basically the perfect person that staffs our LRC clinic, who is a older urologist, kind of general urologist, who had been in community practice, but then kind of rolled into our department several years ago, who is nearing retirement. And he is now, basically just outpatient and has his own full-time clinic. But as he sort of transitions towards retirement, has become our primary faculty to staff the LRC. And I mean, he's just wonderful. I think he's just a wonderful person to begin with, but also because he has seen and done so much in his career, I think he's just a wise and patient person to offer a lot of perspective and advice and clinical acumen for the LRC. And so our current model is that his name is Dr. Geis, but he staffs most of the clinics. And from a supervising perspective, in order for billing to be legal, each patient has to be seen by, technically by a faculty member. And so our expectation is that the staff who is staffing the clinic that day does pop their head in, but it is intentionally in a pretty short or vague way. The primary doctor is the resident, and the attending is there just to bless the case and make billing legal. There are some days that Dr. Geis does not staff, and on those days we have a bit of a rotation of various faculty that will step in. And I think that is helpful to the residents to sometimes have different perspectives and things like that. I think the pros of having one person do it are a little bit of underlying continuity, but I would say a con, and something that I think we'll explore more when Dr. Geis retires, is that, part of LRC would be exploring or experiencing a lot of different ways of doing similar things. And so I think having a more robust cohort of faculty staffing the clinic can be a good thing too.
Yeah, those are really good perspectives. I can also affirm that Dr. Geis is the perfect man for this job, and and it creates a really special opportunity with him there. But I think you're right. There's definitely pros and cons to having one voice or having several. All right. So for both of you, real quickly, as we sort of summarize this section talking about what this longitudinal resident clinic is, can you guys summarize for me the main selling points for this LRC model? Why would somebody consider doing this?
I think my favorite thing about it is the experience to have that patient continuity and not only build relationships with patients, but see them throughout the entire length of their treatment for something. I also think that something unique about urology that I appreciate is that oftentimes we're talking to patients about something pretty uncomfortable or something that makes them feel very vulnerable. And so being able to see them in continuity and build a relationship with them allows them to build that trust with you. And that's a hard relationship to build in a 10-minute clinic visit with an attending that is going to be their primary physician, and they know that they're probably not going to see you in the long term. So I think the long-term relationship with patients portion is really special to me. Outside of that, not so much a special portion of it, but being able to learn how to manage your time in a clinic, know that you are the one making patients wait if you're taking too long in one of the rooms, and being able to manage your time responsibly, figuring out when in your day to call your patients back to talk about their test results, and just really fit in all of the logistical aspects, answering patient messages, communicating with your nurses who are answering your patient phone calls, all of the side aspects that you really don't experience in an attendings clinic because they're the ones managing all of those things are put on you. And as you get more patients that you're following throughout the years, there's more of that responsibility. And I think that's an important piece of being a provider that we don't really see until you get pushed out into being an attending and running your own clinic. So it's really nice to have that experience and feel comfortable with that leaving residency.
I would echo that. I think Kayla's right. To me, the main and most fundamental selling point is that I truly believe that our residents come out better prepared to start practice on day one because of this LRC clinic. And to me, that's really, I think, the main selling point is that you're just going to be better prepared for practice for having done this, because this is as close as we could ever get to being able to mimic practice for you. You get to see your patient, you book them for the OR, you do the case, and you follow them up. And very rarely do residents get that experience in any surgical field. And so I think by doing this, we are tapping into a unique experience. And to me, that's the main selling point.
Those are really good points. And as we're getting a little bit closer to a close, I want to switch gears just a little bit and think about this now from sort of an outside perspective. So, thinking of this from the perspective of another program or another resident or faculty somewhere else that's thinking, that sounds great, but how would I do this here? Allie, what from a faculty standpoint would be the barriers or things to think about adopting this kind of a model?
Well, one thing that was a challenge here that I definitely didn't think about or appreciate is space. Truly, like, where are you going to conduct this clinic? And for some training programs, they don't have a true general urology clinic or practice that they can tap into. It's a lot of like siloed sort of subspecialty clinics. And so one thing I think that's important is to think about what population are you drawing from? Where are you going to house this clinic, and who is going to staff it? And I don't mean the faculty or the residents, but like, do you have an MA? Do you have a dedicated nurse? Do you have check-in staff? Who's scheduling these cases? And so that's, I think, one of the biggest hurdles to starting a clinic like this is just thinking about, you're basically getting a new practice off the ground. And do you have the space and personnel to support that? Because without those things, this does not work.
Kayla, from your perspective, what are some hurdles that you've seen or things that have improved or needed to improve over time to make this work from a resident perspective?
I echo everything that she had said, because I think the biggest hurdle from our perspective has been getting the support to have patients roomed and answer the patient messages and do all of the things from a running the clinic perspective that we are not necessarily involved in. And I think that has kind of been a transition throughout the years as this has been built. But at this point, we have 2 4s, 2 5s, a 2 and a 3 doing clinic for a half day every single week. So that's 6 people doing a half day, 3 full days of clinic, where there are patients who are going to be calling the clinic with questions, messaging the portal, looking at results and having questions, and all of those need to be addressed. And so a big part of that is making sure that we have support staff in order to help us manage that, so that patients don't feel like they're being kind of left in the dust and that nobody is addressing their issues and concerns. I think making sure that you have adequate support staff to be able to handle all of those things is important to make the clinic run and have it be successful from an educational perspective, and also from a billing and logistical standpoint.
So either of you, if someone was going to try to do something similar at their institution, who would be the key stakeholders that they need to engage and work with?
Well, I think from my perspective, number one, the faculty, because without their conceptual sort of support and buy-in, the clinic will never be successful, because you do have to understand they're going to be away from your clinic on their LRC day, or your OR on their LRC day, or they're going to leave your cases to go do their LRC case. So I think faculty buy-in is crucial. So those are, number one stakeholder. Number two is, where is your, I shouldn't say funds flow, that's not what I mean, but how is your practice structured or your department structured, and who holds the purse strings for making sure that you have the personnel that you need, like we discussed, like an MA or a nurse, things like that. So that person is obviously key, or that sort of network of people is key. And then third thing is just the residents, and making sure that they understand how important it is. And, early on in residency, that may not be clear to them, because they're just at a different, place in their learning, and probably don't quite appreciate how important clinic can be. And so to me, the three main stakeholders are the faculty, sort of the ancillary or management piece of things, and then the residents themselves.
Thanks, Allie. Kayla, do you have any thoughts on that, or do you have any thoughts for a resident who still might feel like ambulatory education is not something they really want much of?
First of all, I agree with absolutely everything she said. I think all of those people are key in making it truly feel like it is your clinic and like they're your patients and everything is yours, I guess, from a responsibility standpoint, but also kind of an empowering learning perspective, because sometimes in residency, it's hard to actually feel like you are making a big impact on patients and seeing them kind of beyond the acute moment that you're taking care of them in the hospital. And I think that that's really inspiring and a big reason we do what we do. And so being able to be a part of that and experience that and learn from that and use that to motivate you throughout residency has been something that I'm really appreciative of.
That's awesome. Allie, just a couple more questions here, I think. Allie, do you think that there are any pieces of this that could be implemented or principles that could be gleaned from this LRC experience that could improve ambulatory education for residents elsewhere without sort of launching this full LRC structure? Are there pieces you can pick out of this that you think are takeaways without, as you put it, building a practice from the ground up?
Yeah, I do. And I think that that is a really reasonable place for a lot of programs to start, is like, what can we take away if we can't do the full thing? And one thing that stuck out to me when, kind of thinking about outpatient education, are a couple studies that were done in the general surgery literature, but all said the same thing. And basically they showed that when they looked at a pre-op visit, a operation, and a post-op visit, literally 0% of surgical residents participated in all three. On any given patient that they operated on, only 9% of them had participated in either the pre or the post-op visit, and then 0% in all three. And so I think that's a fundamental flaw in surgical education and what we are attempting to address through the LRC. And so I think one thing that people could take away is that how in our program could we create an experience in which a resident would have an opportunity to see a patient through a course. And so maybe if you're in a mentorship model, or somebody's on a 3-month cancer rotation, whatever it may be, being intentional at the outset of a rotation or an experience such that maybe in the first week or two you say, I want you to identify 2 or 3 patients that you are going to adopt as your own, and you're going to see them through, and I want you to be responsible for them. And so just thinking about continuity in that way, I think is something that any program can take away and model without having to, do the full buy-in. Although we do recommend the full buy-in. It's awesome.
That's great. Kayla, is there anything that you've picked up or learned from the LRC that's changed the way you approach clinic or have approached your time in other attendings clinics?
Yeah, I think that one thing that I used to do in a lot of attendings clinics is kind of use that that encounter to figure out what ways of talking to patients works and what questions feel comfortable or uncomfortable and what explanations work to really make me feel confident and knowledgeable about what I'm explaining to patients and teaching patients. But I think with kind of a different mindset in the LRC is that you don't really have an attending to bail you out when you don't feel comfortable or confident talking about things. It really pushes you to prepare and know why your patients are coming to see you, have looked through their imaging, have a kind of a preliminary plan for them going forward, in a way that most attendings do when they're preparing their clinics, and gives you an opportunity to feel that comfort and that confidence in actually being the one making those decisions and explaining all of the care to your patient. And I think that's changed the way that I approach other attendings clinics too, feeling that comfort level shift so that I don't rely on kind of just asking a history and then saying, okay, well, we'll discuss with you later when the attending comes in what our thoughts are. It's really given me a lot of confidence to say, okay, I know that these are next steps and what questions can I answer for you before they even come in, and probably, hopefully, be more helpful to the attendings whose clinics I am in.
Yeah, those are great thoughts. I think the opportunities to have your perspective changed a little bit about clinic, I think, or what I'm hearing there is you have your eyes open a little bit to maybe all that goes into running a successful clinic. And I think as residents, we don't always appreciate that. So I think that's definitely a big benefit. All right.
Definitely.
Anything from either of you that we didn't discuss or that you feel like is important to mention in regards to the resident clinic?
We touched a good bit on kind of what we see in resident clinic, and that it is a general urology clinic for the most part. But it's not just stones and BPH and overactive bladder. Like, I've had robotic pyeloplasties, I've had patients go for cystectomies, and it pretty much runs the gambit of what is urology. Anything could be in your clinic. I'm managing people's Clomid and doing fertility workups and, like we said, vasectomies and prostate biopsies and gross hematuria workup. And so pretty much every step along the way, if they develop a new urologic problem, they're still your patient. It's still on you. And it allows you to also work with all of the different attendings who are more subspecialized, because that's how you staff your case that you're booking. It really is a wide variety in terms of patient population, things that we are seeing in the clinic, experiences that we get to have. And there's essentially no limit in it. That it is our patient, it's our responsibility. And I think that's just an incredibly unique experience that I have not seen anywhere else.
And that raises a good question. Have you found that this has made you more likely to seek out some of your faculty and ask questions? I mean, for instance, I'd be terrified to prescribe someone Clomid, but have you have you, in some of those situations, have you seen that on your schedule and gone to some of your faculty and sort of sought their advice?
Yeah, absolutely. And it's also helped me see a couple different ways of doing those sorts of things, because, like we've talked about, Dr. Geis is the one who really sees it in that moment. We leave the patient's room, we staff it with him. He helps us come up with recommendations and treatment plans. However, then we go work with the fertility subspecialist who was maybe trained a little bit differently, maybe starts out Clomid at a different prescription, things like that. And we're really able to see different ways that different providers manage things that still works, is just a different way of doing things, and helps us to learn kind of what the thought process is between why they each do that. Brings up a lot of conversations to really get a deeper understanding of how to care for patients and make those decisions on your own after seeing how different providers do it.
Great. Allie, did you have any other comments?
I think one thing that is really crucial, and maybe we didn't mention thoroughly enough, is that I think the patient buy-in is really important. And our experience has been that the patients are totally comfortable with this and are accepting of it and do not want to change physicians. But I think part of that is being transparent with them and upfront, and not making it seem like, you know, it's a secret that it's a trainee or that they're getting less than care or things like that. And so I think one thing that is important, and perhaps another stakeholder even, is the patients themselves and the way that the clinic is framed and explained to the consumer, which is really the patients, because they do have a choice in the matter at the end of the day. And so I think that's one thing, you know, to consider too, is just making sure that you're transparent, truthful, and frame it appropriately, and then people are comfortable.
I completely agree with that. I have had a single patient in the last 2 years switch providers, and I think that it was less because I was a resident and more so because I would not prescribe him a certain medication that he seemed to be seeking in my clinic. But I see a wide variety of patients. I've got some other attendings in different service lines that I see in my clinic, and all of them know that I'm a resident. Many of them have come in and have looked me up online and know my background and where I went to undergrad and bring that up in conversation. And that has never been an issue, and I think continues to support us doing this because the patients put all of their trust in us and kind of trust the model and our knowledge base and responsibility. And that's a really cool part of it.
All right. Well, Allie, Kayla, thank you both for sharing your experience and the unique insight that you guys have on ambulatory education for urology residents. It has been a true pleasure to discuss this and highlight the longitudinal resident clinic that's happening at Carolinas Medical Center. And I'm so especially thankful to know both of you as well, both as mentor and co-resident and as friends. So thank you both for your time, and thank you all for listening with us.
Thank you, Sam. It was a pleasure. This was fun. I appreciate you having me.
Absolutely. Happy to share this experience with other people, and hope that it gets some other programs interested and that people can glean something from it.
This has been an AUA News Inside Track podcast, brought to you by the Residents and Fellows Committee. For more information about the AUA and AUA membership, visit auanet.org/membership.